Nick Trevellis. I'm a member of the AOCPMR National Student Council on the Research Committee. I am so excited and honored to get to introduce Dr. Ben Katholi of Shirley Ryan Ability Lab. A little bit about Dr. Katholi. He completed his residency training in physiatry at University of Minnesota, and he followed that with his pediatric fellowship actually at Shirley Ryan Ability Lab when they were known as Rehab Institute of Chicago. And after graduating from there, he worked at the Cleveland Clinic in pediatric physiatry for several years. Since then, he's returned to working at Shirley Ryan Ability Lab. And in addition to his allopathic training, he's actually taken it upon himself to expand his range and understanding of different treatment modalities. These include acupuncture, they include frequency specific microcurrent, which we're going to hear about tonight, and they also include OMT. He's certified in fascial distortion model, which is a specific type of osteopathic manipulative treatment, and enjoys using this and other techniques on his patients who live with chronic pain. And he's an incredibly warm physician. We're very lucky to have him tonight. Everybody, ladies and gentlemen, Dr. Katholi.
Thanks, Nick. Let me pull up my slides here. So I was going to start off by just kind of, so I know a few people here are familiar with FSM or frequency specific microcurrent, but kind of wanted to introduce it. It's sort of growing in the rehab world in a number of other areas. The literature on it is not large scale, it's kind of small studies, but they're pretty interesting. And so kind of wanted to talk about kind of two examples of what's been looked at and kind of some things of what we're hoping to do with it in the future. And I want to make this pretty casual, so if anybody, feel free to interrupt me if you have questions or anything like that. So I wanted to talk about, so there's traditional microcurrent and then there's frequency specific microcurrent. So we'll talk a little bit about both of those. And just sort of as a disclaimer, this is like a 4 or 5 day course, and so we're going to shrink it down to like 15 minutes. So I apologize. But a little bit about how it's administered, and then we'll kind of go over 2 studies. And then we've done a lot of case reports at national conferences with this, and and so it's being used in a lot of different ways. In rehab itself, there's a lot of different electrical stim modalities. So there's neuromuscular electrical stim, which is used for muscle firing, or also to kind of help reduce muscle spasms. There's TENS units, which are useful for blocking pain. And those kind of work on gait control theory, where you overwhelm the spinal cord receptors for a period of a couple hours. Vital stim is a tool that's used in speech therapy, and it helps with dysphagia and helping with controlling muscles involved in swallowing. There's been some more recent research in terms of high voltage current. Iontophoresis is a modality that's used a lot in the sports world to drive medication into tissues using electrical current. And so it's administered by PT and OT a lot. And then you'll hear about functional electrical stim, and people will be on kind of patterned bikes or treadmills that kind of help with movement. And so they're used a lot in like spinal cord injury. Microcurrent itself, it's been on the market for a number of years. And really the thing that really helped it hit the market is this is when microprocessors were developed. And so you could have a consistent current at a very low amperage. So this is like very small currents by comparison compared to like electrical stimulation. So it's not enough to really activate muscle firing or sensory nerve firing, but some people can feel a little bit of sensation the stimulation. So it's very mild. So that was one of the things that drove me to get into it. And it was first studied for pain or to help with tissue healing after injuries. And there's an example in the lower corner there of kind of a box that we used to use. Well, actually, I still use them for home. And they're used a lot for pain management. And how I got into it was in acupuncture. We use microcurrent to stimulate acupuncture points. And a lot of kids obviously don't like the idea of needles. And so we started playing with putting patches over acupuncture points to stimulate simple treatments to help kids who are nauseated after chemotherapy, who have post-operative pain. And we had a lot of luck with it, but then there were some patients that weren't responding, and we started to look at what else was out there in terms of electrical stim. And I played with a lot of different devices to try to figure out what would be good for the rehab population. And I stumbled across FSM. And so traditional microcurrent has been used a lot for macular degeneration. If you get on Amazon and Google it, you'll see a lot of cosmetic applications. How does it work? So high-level stim can really reduce ATP production, at least on several studies that have not been repeated, but they were done kind of in the 80s. Microcurrent with low-level stimulation of less than 500 microamps has been proposed to aid in ATP production. And we'll talk about in a few slides kind of what they have seen with that in addition to just ATP production. But what we know is that in injured tissues, there's lower counts of mitochondria, there's lower energy production, and so there's delayed healing. And so, this isn't the only modality out there that targets this. Laser stimulation, there's a number of different types of electrical stimulation. Ultrasound therapy has, to some extent, will trigger tissue repair as well. Heat modalities can trigger tissue repair as well. But anyway, this is the proposed mechanism of how we think it works. So we'll talk a little bit about what FSM is by comparison, but I wanted to kind of introduce a couple topics, and one of those is resonance. And this is something that we're looking at with microcurrent specifically. And what this means is that they have seen that certain tissues respond to specific electrical or sound frequencies. And it doesn't have to be a huge stimulation to have a large effect. But they've noticed that there are resonant frequencies for different textures of, not just human tissue. And an example is if you're a musician, it's not hitting the note, but hitting a consistent and sustained sound frequency. Certain singers can break glass just by singing. Obviously, we don't want to break stuff. If you listen to different instruments, there's the notes on top, and then there's what's called harmonic frequencies. And that's how FSM works, is on harmonic frequencies. There's 7 harmonic waveforms that they've seen on kind of fine wire surface EMG. And that's what they think has the bigger effect on tissues. And this would be sort of one more sound example. And so this is just water lit up under a plate by UV light. And you can see with different musical notes how they can cause the water to reorganize, which is crazy, right? So you can program molecules in water using sound. So it shows this demonstrates that you can move molecules with resonant patterns. How that applies to humans is that we can have sustained effects on tissues if we're using the right frequencies. So microcurrent is sort of new and sort of old. So these electrical frequencies actually came from turn of the century from some osteopaths, actually. So there were some physicians in the US and the UK, and if to kind of give you a frame of reference, this is pre-penicillin, a lot of standard medication, and it was also in the realm of a lot of innovative and maybe some harmful treatments too, right? It's where the kind of phrase, the snake oil medicine, and this is before the government sort of jumped in and started regulating medicine. And one of the things that they were looking at that really wasn't validated, but they were trying to figure out if they could affect infections with either light or sound frequencies. What they didn't have was they didn't have microprocessors, and they didn't have a way to apply current in a sustained fashion. But they were having an effect, and sort of a lot of this stuff kind of got tabled. It stayed in the community, but there were, big advances in medications. Penicillin got developed. There was a big effort in terms of Western approaches, right? And this stuff stayed out there, but was not well known about. And a lot of this stuff was not accessible because they didn't have the right equipment. So in 1979, when microcurrent was developed, these frequencies came back into play, and there were a couple sets of practitioners who started experimenting with these frequency pairs again. And they were able to start seeing the benefit of these. And one of them was from an osteopathic practice that then got bought out, or the equipment was bought by a chiropractic practice. That was Dr. McMakin. And so she sort of coined this term, but she's not the only person out there that's been researching it or developing it, but she's probably the most prominent person. And so she's the person that one of the studies that we're presenting today. And what this means is that instead of a single frequency, these devices will provide two separate combined frequencies, meaning that you have the ability to treat a tissue and a condition, and it makes it specific to the patient and the condition rather than just treating a nerve specifically, for instance. And so the notion of interferential current means that it's where those channels of this electrical frequency cross in the body and have that defined effect. And so we talked about this resonance, and this is something that you can palpate on exam and is like sort of immediate. We've been able to see it on ultrasound with bigger tissues. So it's not totally in our head. You can, if we're treating tendons, you can see vibration of the tendons on ultrasound, and we've captured it on video. So it's very interesting. And so I ran across this at the AOCPMR conference, and was able to be treated and tried it out and decided to get trained. And that sort of set me on my path of kind of going down the rabbit hole with this. So it's a very interesting modality. What you need for it, and this is a sample patient, so this is PT Bert. So this guy actually was somebody needed him for therapy he needed to demonstrate the exercises, and then the patient would do the exercises in PT. So we borrowed Bert for showing FSM setup. So this is a sample unit that we had in Cleveland. And what it requires is 2 independent channels that can be programmed to 3 or 4 digit specificity. The ability to have this constant current generator is the biggest thing. But the ability to do alternating or kind of positive current has also opened up a lot of possibilities with it. So the waveforms aren't unique, but the frequencies that are created by them are, and that's what has the effects on the tissues. And so it sounds really far-fetched, and roll with me. So some of the first studies that were looked at with this, with microcurrent in general, so we talked about ATP production. And this is only in injured tissues. So that's the interesting part, is it's not in other tissues, it's only in injured tissues. They saw changes in amino acid transport, protein synthesis, signal transduction, and changes in cytokine signaling. And so the first study we're going to talk about is the effects that they saw in cytokine production. So we talked a little bit about how this works, and why it works on the body is that we're wired like a battery, positive to negative, top to bottom and front to back. So if you take polarity measurements of the body, the top of your head is very positively charged and your soles are negatively charged, and the same with the back. And what it has to do with is the direction of nerve firing, and how that transmits current. And we know that we're able to store current, right? If you scuff your feet across the carpet and then shock your roommate, you know that you're able to store current and transmit current. And so using that, we know that, and we saw in those pictures that we see that water is able to be reorganized and transmit. And since your body is a large portion water, that helps. What do we see when we treat people? So there are kind of immediate effects. There's a relaxation of the tissues. There's a big autonomic response. You can palpate resonance at really injured tissues. If you are trained in palpating cranial rhythm, it changes cranial rhythm significantly. So it makes craniosacral therapy go a lot quicker. We get pretty quick reduction in pain, but only if we're targeting the right tissues. And there can be lasting effects on this depending on what tissue you're treating. So the differences is that peripheral tissues respond differently than central nervous system tissues. And that's something that we want to research a little bit and work with. So if a question we get asked a lot is, how does this compare to TENS units? And these are actually licensed as a TENS unit. The FDA says it has a battery and wires and it's used to treat pain, so it must be a TENS unit. So that's the category it's in. And that's fine. But they are different. And I'm not opposed to TENS units, like I'm not bashing them at all, but in the sort of few studies that were done comparing the two, they saw a big increase in ATP production with microcurrent. And with TENS units, there's a potential, especially in new injuries, anything above 500 microamps tended to decrease amino acid production, worsen cytokine signaling actually, and it can be painful, but it also decreased ATP production, which validating that, those studies were done in the 80s. Has anybody restudied that? I don't think so. So I I don't avoid the use of TENS units, and if I don't have luck with tissue specificity, I still use lots of TENS units. So, but I think what we know about TENS units is that they're good for blocking pain, but the body accommodates to them quickly because of the high intensity of it. And so the average sort of length of use consistently is a couple months, and then a lot of times they end up in grandma's drawer unless somebody else injures their knee, and then they get pulled back out. So there's still a nice treatment modality, and there's a lot of neat studies with TENS units, but I don't use them for wound healing or tissue injury. But it'd be, anyway, those are a couple studies and not like sort of widely replicated. So I don't entirely put all my faith in it, but it's something to kind of base our thought process on at the very least. FSM is dependent on the health of the patient. And so, you know, if we know the tissue that's injured, it works great. If people are well hydrated, and also if they're healthy, you know, like any process, if you're an 80-year-old smoker that eats 3 meals a day at fast food versus a healthy 16-year-old patient, you know, who both injured their knee, they're going to heal up differently. You know, and there's good studies showing that the healing of low back pain is very different in smokers versus non-smokers, right? So we, and that goes with this modality or any treatment modality. People respond better if they treat their body correctly. And this doesn't work on tissues that aren't there. So, you know, if you blow out a ligament, you can't put it back together with this, but if you strain a ligament, you can help with tissue repair. But some things are surgical, and that you just have to know your lane and sort of stay in it. So this is kind of the short list of the stuff we've treated with it. It's, you know, depending on the practice. So the people that are doing this, MDs, DOs, PT, OT, speech, psychology, massage therapists, some nurses. So a huge variety of treatment specialties and what people are doing with it. And I think, you know, everybody has their area of interest. And I don't treat a lot of allergies, right? Because in rehab, and that's not what people to come to see me for. But we do, you know, if you're not familiar with pediatric rehab, we see a lot of kind of chronic disabling conditions like cerebral palsy, spina bifida, brachial plexus injuries, spinal cord injuries, brain injuries, chronic pain, amputations. And so you could see where a modality like this would be useful in a lot of venues. So we treat a lot of musculoskeletal injuries, a lot of neuropathic pain, and this has been sort of well validated in nerve pain. Arthritis, torticollis, so we'll talk about torticollis. Viscerally referred pain is super interesting because there's not a lot of treatment modalities out there that can help with that. And the other interesting one, we were sort of mentioning it before we got started, is I have some colleagues who are studying ADHD in Cleveland. And so they have presented at a couple conferences in terms of pre and post outcomes with that. And then we were trying to do a feeding disorder study in Cleveland, but it didn't get off the ground before I left. But it's all of these are focused on what tissue do you go after to try to change function. And the big thing is this is a tool in your toolbox, but this doesn't replace the importance of therapies or nutritional counseling or any other effort. You know, this doesn't make people stronger. But this, I think, is useful for quality of life. One of the things that we're doing here in a lot of patients is treating a lot of hypermobility syndrome related pain. You know, we're not going to get rid of rheumatoid arthritis, and we're not going to get rid of Ehlers-Danlos which is a genetically based connective tissue disorder that causes kind of widespread hypermobility and pain. And it's been really useful for those patients. And so we see an increasing number of those patients being treated around the country with this modality.
Quick question actually from
Yeah.
Maggie in the chat. She asks about target tissues for treating anxiety and depression or ADHD.
Yeah, so with anxiety and actually the ADHD treatment is based on the treatment for anxiety because a prominent symptom in ADHD is anxiety symptoms, along with some of the attentional difficulties and, executive functioning difficulties that we see. And some of these programs we've written and some of them we haven't, right? So I didn't develop the anxiety program, but to the best of my knowledge, it targets frontal lobe and some of the limbic structures, but I cannot remember all off the top of my head. But there's been some really interesting research with microcurrent in general, not just FSM, but a few other microcurrent modalities like alpha stim, which is an auricular-based treatment. And the evidence for that, there's hundreds of papers on it, actually. It's really well validated. And they see in those studies a decreasing need for medication, meaning that people are able to reduce the dosage of medication significantly. And if you have difficulty with medication side effects, that's beneficial. So that one is validated for anxiety, depression, insomnia, and pain. And we use that here too. And it works a little bit differently, but there are a lot of neat studies going on, especially up in Canada, with mood disorders with microcurrent. So it's a neat neat treatment for it. And I think you have access to hundreds and hundreds of frequency pairs, but I think when it comes down to it, the most important thing that we can look at is a history and a really good physical exam. And I think that's important in any rehab practice, right? And I'm big on neuro exams, and the things that I really find useful are like dermatomal exams, reflexes, gait, and also just, good musculoskeletal exam to help localize symptoms. And also, is there anything that could affect the success of treatment? Because there are some contraindications to this. So we can treat implanted hardware. Seizures doesn't seem to be a problem. These are sort of lists from the FDA, and I would say the ones that we don't go near are pregnancy, because it's cytokine dependent, and we know that this decreases cytokine signaling. So you don't treat pregnant patients. Malignancy, if people are palliative, we treat pain, but you don't treat cancer with this. That's not what it's for. And you have to alter treatments with spinal stenosis. You can't polarize the current because people feel bad. And then there are, depending if people have had surgery, there's some frequency pairs that you avoid, because this actually affects scar tissue and can soften scar tissue. So kind of the evidence out there, there are not large scale RCTs out there. There are a number of small scale studies, and they're all super interesting, but they're not at the level of, some of the other research that's been done in other modalities like TCDS or transcranial direct current, or some of those are better validated. And but there are a number of centers that are starting to get into research with this. So the military has a couple centers. Fort Bragg is doing a lot with it. Bethesda is doing a lot with it. Cincinnati Children's is fresh underway and trying to get going with it. And so there are a number of kind of hospital systems. Cleveland, we were one of the first major systems to really get heavily involved in it. And so, you know, I think that there's a lot of attention to the clinic just because we have a ton of people trained there. And so they've been doing a lot of really interesting stuff with it, but it's mostly pediatric there, but there are some adult practitioners there doing it. I spent a long time trying to get more people involved in it in the, you know, 9 years I was there. But, you know, everybody's busy and everything is the next best thing. So when you try to explain it to people, like I said, it sounds a little far-fetched, and then you just sort of, if it's something that interests you, you try it, and it's, you know, it either intrigues you or it doesn't. Kind of before we move on to talking about the first article, are there any questions? I know that I kind of zipped through that really fast. Does that all sort of make sense generally? Okay, so basically, and I didn't want to get heavy into the technical aspects of it, but basically we have two separate channels. One is condition and one is tissue. And so the ability, there's condition, examples of condition frequencies would be like inflammation, scarring, swelling, kind of chronic inflammation. And there's hundreds of those. And there's also hundreds and hundreds of tissues that have been identified, some by trial and error and some sort of from the list from the early DOs in the early 1900s. And there's some that have been crossed off because they were worthless, right? So it's not like they just keep adding some. There's some that have been found not to be that helpful and were sort of tabled and taken off the list of traditionally taught frequencies. So one, we mentioned Dr. McMakin earlier, and so she has done some different research with it. And she started off with 2 articles, one on myofascial pain syndromes, and had a lot of success with that. And she also did a study on neuropathic pain. And then they moved into, you know, trying to figure out what this was doing at a cellular level. And she, just as a part of her practice, ended up getting a ton of referrals for fibromyalgia just because of the success. So it was sort of like the success of the modality built her practice, and sort of that's what, now she's like a fibro guru among other things. Fibromyalgia is a really generic term, and it is overused, and you'll hear a lot of arguments about whether people have it or not. But in general, this is a widespread chronic pain disorder that needs to be present for more than a couple months. And it's accompanied by multiple other symptoms that sort of help clarify the diagnosis. Among them are fatigue, sleep, memory, and mood difficulties. Well, that sounds like every chronic pain disorder, right? The American College of Rheumatology used to promote a tender point exam as part of the diagnosis, and now it's really past that. But it used to be that if you met 11 of 18 tender points, then you, quote, had fibro. But there's a lot of people who meet those tender point criteria, but don't necessarily have this widespread pain sensitivity or kind of cognitive dysfunction. So it's a very broad term, and I don't get wrapped up in it. I try to look at what patients are doing functionally and really look at it a big picture rather than, you know, I think the biggest challenge that people have as practitioners is trying to make people fit into a bucket. You have patellofemoral pain syndrome. Okay, maybe you don't. Maybe you just have fascial tightness, or maybe you just have weakness in a different muscle, you know, and so we try to make people fit into these buckets. And, you know, just keep a broad differential, and you know, there's a lot of things that contribute to physical symptoms of any type. With fibro, there's a broad number of triggers. So people will talk about physical or emotional trauma, and literally like emotional trauma, like kind of catastrophic loss, you know, divorce, loss of a relative or a sibling, surgery, infection. Obesity is interesting. So, and it's not that they're in pain because they're heavy set, but there's newer evidence, actually, some recent research that showed that there's triggers for osteoarthritis, not because of mechanical stress, but actually because of the pro-inflammatory state of adipose itself. So it triggers, in fibromyalgia, triggers high levels of cytokines, which influence pain levels. Repetitive stress injuries, meaning, you know, if I type all day long and I develop hand pain and it spreads to the rest of my body, that can be a trigger. And then family history, actually genetics. So 10% of chronic pain is inherited. There are some specific genes, definitely in fibro and in a few other categories that, you know, you'll hear arguments that people, you know, it's just the environment they grew up in, but they're actually genes that have been identified that have been implicated in chronic pain syndromes. This has a higher preponderance in female greater than males. And then there's some associated kind of characteristics that we see in fibro. So this has really actually become to been thought of as more of a neuroendocrine disorder. We see altered levels of multiple hormones and neurotransmitters in the body. And these people have really altered pain perception, meaning if you put an EEG on them, they've got really elevated responses to pain. If you do SPECT imaging on them, they have different blood flow to the thalamus and the caudate nucleus. And they have this really sensitivity to non-noxious stimuli. And so one of the highest triggers is kind of whiplash or cervical trauma. And so there's a 13 times higher association of fibro after cervical injuries. And so that's what they sort of started looking at, because it would be the only sort of homogeneous population that they could pick because of all of the other sort of influences that help develop chronic pain. In general, not just for fibro, but in general with longstanding chronic pain, people can have higher level of inflammatory cytokines. So interleukin 1 and 6 are often studied in arthritis and a number of other disorders. And they're sort of measured as sort of acute markers for how treatments are affecting people. If you're in pain for a long time, your body has stress responses and has elevated cortisol, which then leads to a widespread number of other issues. It thins the gut wall. People have a lot of allergic reactions and food sensitivities. So it's a big downstream effect. And they're looking at some of these in like cerebral palsy and why chronic pain is present in CP in about 70% of the patients. And so there's a Dr. Jayabalan here. We're involved with some research with him doing that. So this study, it's a small study, and it's interesting study. So they paired up with a researcher from the NIH, Terry Phillips, who assisted them with this study. But essentially, they identified 54 fibro patients who had a history of cervical trauma and met their criteria. at that time when they did this study, that was still in the ACR criteria of tender point exam. People haven't dismissed tender point exams, but there's more to the diagnosis than just the tender point exam. What's really interesting when you look, and so this would be a sort of, if you look at pain diagrams on patients, it tells you a lot about where their pain could be originating from. And what you'll notice is that they circle, many of the patients will circle their hands and the bottom of their feet. And there is a greater number of nerve endings distally. And they will have sensitivity to touch along their posterior spine in specific areas or diffusely. And pain begets pain, so it spreads, and that's how you start off with lumbar, low back pain, and all of a sudden you have your whole body hurts because of substance P release and affecting different nerve roots. They identified some frequency pairs in these, kind of through trial and error, that affected inflammatory responses and pain pathways, and they wanted to validate it in these patients. Now, this was a self-funded study. So number one, that's a bias, right? So they were only able to do lab draws on a small number of these patients. But what they did was, so they had 54 patients who met the current ACR criteria back in 2005, or actually 2003 when they did the study. And they drew blood samples for some of these inflammatory cytokines on 6 of the patients. And they also tracked VAS scores, or visual analog pain scores, with these patients, and saw pretty dramatic changes. And these have been replicated at multiple centers. The blood tests less so, but the pain responses definitely. And I didn't mention it, but there's about over 4,000 practitioners in 23 countries worldwide doing this. So this is happening in multiple countries, but fibro is very common in this country, and you'll hear a lot of debate on why that is. But wanted to kind of point out a couple pertinent findings from this study. But they spent a lot of time classifying these patients, and kind of the setup for this, if you looked at the study, was we polarized the current, they polarized the current kind of neck to feet. And the pictures, it looks super creepy. They used black graphite gloves, which looks, yeah, we don't use those. But you'll still see it in some pictures of old textbooks. Now we just use alligator clips on wet towels. So you can apply this current with electrodes, wet towels, or a magnetic converter. And in this study, these people had dramatic benefit in terms of sustained drop in pain levels over multiple weeks. And so you'll see this, what the selected frequencies they used are 40 and 10. So 40 is a conditioned frequency for inflammation, and 10 is the identified frequency for the spinal cord. And what the theory they have is that they're decreasing substance P release in the spinal cord. There's been a few other kind of case reports where they did GABA sampling, and they saw altered GABA levels in patients with chronic pain. So it's super interesting. And then sort of the blood sample collection for this, they did blood lancet studies. So sampling interleukins is tough to do, but they did this immunofluorescence technique. And if you draw, so one of the criticisms of this study is that if you sample people and you draw 3 sequential labs, you may get a variety of differences. And so if you're in clinical practice, it's not common to draw interleukins on people. This is a research-based blood draw, and I don't even know if I could order them here. I have no clue. But the researchers can, and they're run through the Northwestern labs and I don't know if they even send some of those off to Mayo. Some of those may be shipped to Mayo, but Mayo does a lot of this as well as NIH. So this study, the kind of outcomes for this were super interesting. So there were some non-responders. And these are the drops in interleukin-1 levels. And they had a control person who I think they ran random frequencies on. And so here's the control, and he really didn't change. But you'll see these sustained drops in interleukin levels, and that matches up with decreased. So the sort of average beginning level was around 330 for their mean, and their average endpoint was 80, which is a pretty dramatic shift. That's in 90 minutes. So that's insane to be able to drop inflammatory markers in 90 minutes. That's kind of unheard of. The same thing with TNF alpha. Now, that was interesting because there's this, it didn't return to baseline. So there's this drop between the visits, it does spike back up. And TNF alpha is a secondary marker, and it's later down the inflammatory pathway. But again, a pretty dramatic shift. And if you're familiar with p-values, this is a very low p-value. Whether that p-value is valid because of the sample size, that I'm not sure. Substance P is a pro-inflammatory marker for pain. And it's been validated to kind of promote the spread of chronic pain through the body. So all of these are very interesting. What I found interesting, there's again big jumps in this, and you see the control again, none of the sort of random frequencies affected the control patient. There was only one control, right? So that's a weakness of the study. If you were doing an RCT, you'd have matched pairs across both, right? Because there's going to be a certain amount of placebo responders or non-responders. If you're familiar with endorphins, that's the feel-good chemicals that your body releases after you exercise or do deep breathing exercises with your resident psychologist. So there's a lot of ways to promote endorphin release. And exercise has effects on cytokine levels, but endorphins like this, saying sort of sustained like this, you don't see in a short period like this. They gradually respond. And again, endorphins are remarkably difficult. They vary minute to minute. So this one, they saw changes in it over time. But I'm not sure how to place this in the more important thing to me was sort of the pain scale with these patients. And in general, they had a significant, so their average VAS score was in the 7 out of 10 range, and their end range was around 1, which doesn't happen with fibromyalgia. These are patients that stay in long-standing pain forever, until they exercise, take control of their diet, and it's a multidisciplinary treatment. And this is not the only tool for it, but it was very interesting, the response rate in this. So everybody that they treated experienced pain relief. They had some people discontinue treatment, and they said it was not related to treatment side effects. It wasn't clear, and you'll have dropout in every study. But these people had improved tender point sensitivity, which is really valid. I think sleep quality is a very good measure of any pain study, because pain is really, it has dramatic effects on sleep. And there was somebody that didn't do well, and and that's to be expected. Anything that can help can hurt, right? So let's drill a few holes in the study, because we said a few things. So this isn't a huge group, and I think that when we've talked with statisticians, calculating the p-value in this sample size would be tough. And they only were able to afford to draw a blood sample on a small number of those patients. And so, did this happen with all the patients? Everybody experienced pain relief, but did everybody have reduction in inflammatory markers? We hope so, but we don't know. But that is a little bit of, and I may have missed it in the study, but I don't know how they identified who they drew markers from, but it gives you a notion of maybe some bias there. Let's pick a winner. But the high chronicity of symptoms, so the average length of symptoms for these people was anywhere from like 1 to like 40 years or something like that. But the average chronicity was 9 years, which is, so these are not people who developed pain a couple months ago and are looking for anything to help them. These are people that have been through everything and it didn't help. They didn't really look at functional outcomes. And so some of the things that I think are important would be like a Beck depression inventory, a quality of life scale, maybe some physical functioning like ADLs. And so there's a lot of rehab criteria that you could toss into this if you replicated this study to, do these people feel better, but does that mean they're functioning better? Did they go back to work? Are they in the ER less? What's their sleep wave outcomes? So there's a lot of extra things that you could do, but it's a very interesting study, and it shows you kind of, it validates what we see with this, which is when it works really well, but there's patients that don't feel good with it, and it doesn't work for everybody. And kind of how I would apply it to you guys' area of interest. This is a great manual tool, meaning if you are able to, if you like manual medicine, which I'm a big fan of, I'm not credentialed for HVLA, but I do a lot of muscle energy technique, BLT, occipital release, cranial therapy, anything manual that I can, and I don't think HVLA has its place, but it's not my background in training, but I like the manual techniques. And I think what I've found is that this really enhances how you connect with patients and how quickly you can get a response from them. So if you have an interest in sort of continuing with any manual techniques after your training, the benefits are, this isn't painful. It goes well with manual techniques. It makes it work quicker, so you don't have to work as hard. It promotes self-healing. It kind of incorporates structure and function of patients, and enhances your goals of improving health of the patients, right? Which is your big goal. And we're at 7. If people need to roll, I won't be insulted. If you want to cover the torticollis, we can go into that a little bit. You guys tell me what you want to do. I know people have to study or eat or do stuff, so you tell me what you would like.
Up to you guys. We can take a group poll and raise your hand if you're wanting a little bit of the torticollis, or raise your hand if you've got it. Does anybody have any questions at this time? How about that? If you've got
Sorry.
any questions, go ahead,
Oh,
Alan.
oh, sorry. The hand raise was just for, yeah, let's do torticollis. Sorry, it wasn't specifically for a question. Thank you.
All right. Cool. Well, we can, if you need to run, go for it. And if you're sticking around, fabulous. So torticollis, you know, we see juvenile fibromyalgia. Torticollis we see a lot of. So my background, we saw a lot of torticollis, and the traditional treatment route for torticollis is, you know, people see their pediatrician, they identify a concern, and people are referred to PT. And the only people that we end up seeing in physiatry are people that are really chronic. I have a little bit of a warped view of it because I'm in brachial plexus clinic, and there's a lot of comorbid torticollis with brachial plexus injuries. And so we see a lot of these patients. So I ended up seeing a lot of them in Cleveland and developing some techniques for it that then were sort of the basis for the study we're going to go over. But essentially, torticollis itself is Latin for twisted neck, which sounds really morbid, but congenital torticollis is very different than when you hear about spasmodic torticollis, which is a dystonia that occurs often in the cervical spine and is treated often with botulinum toxin injections and a lot of other maneuvers. Traditional torticollis, it's not painful for the most part, but it's due to intrauterine position. So if you have a kind of a very small mom, or a atypical lie in the womb, or if you have a muscle injury, and if you have, there's a number of kind of risk factors for torticollis. Most of the time it goes away pretty quickly with a couple sessions of physical therapy. They teach them special holds. Actually, OT and PT both can work with it. And I think if you are in the community, it's viewed as very benign. And if you talk to a therapist who's in division or vestibular, there's a lot of issues. So there's a few studies that looked at learning disability in torticollis, and there's actually difficulty with reading and perception, 3D perception. So it's not totally benign, because if you sort of grow up with a tilted view of the world, it throws things off, you know, aside from having neck pain and contracture. And there's some craniofacial deformation that happens because of the pull of the tight muscles. So it can be postural, and that's pretty benign. It can be muscular with muscle tightness, or there can be fibrotic. And the study we're going to talk about is sort of the worst of the worst. Torticollis itself is really common. It's like 1 in 300 births. Most of the time they see therapies and they don't need a physiatrist. But there are cases where people have injury to the SCM muscle, which is, it's a double branch muscle. So there's a sternal and a clavicular head that comes down and attaches at the neck, and it's responsible for head tilt and contralateral rotation. So this baby that you're looking at in the picture has left SCM tightness and probably has some scalene. He's kind of hiked his shoulder. She's kind of hiked her shoulder a little bit, and I'd suspect there's some trap involvement there too. So it can be a complex issue in terms of if there's chronicity. When muscles are injured during the birth process, blood deposits in the tissue and causes calcification and can cause fibrosis. And those are people that either need Botox or surgical intervention. I have never referred for surgical intervention. I've read about it, but I haven't run across it. If this child that is in the study was met by a surgeon, I think he could have ended up having surgery. Thankfully, he met Regina instead. But he was actually referred to a surgeon for assessment, and they wanted to see what the outcome of this was before they'd even consider anything. But when you can avoid it, let's not cut on babies. So interestingly enough, there's two nice studies out there on torticollis previously, and they're not FSM, but they looked at microcurrent effects, and what they showed was relaxation of the muscles so that the babies would be in less discomfort to stretch. And they did see benefit to it. I mean, they were really nice RCT studies. If people are interested, I can send you them. They were out of Korea. I think it's Dr. Kim. Based on that, we started developing some techniques for how we would approach it from an FSM perspective. And what we looked at is targeting nerve innervation to the muscles involved in torticollis. And so that meant targeting the medulla, which innervates the SCM and some of the cervical paraspinal muscles, and then targeting root level innervation to some of the cervical paraspinals. And we were having a lot of benefit to those, but we were not treating the patients that Regina saw. So she met this patient, and at the time he had been in therapy. He was sort of late identified, but very chronic. So there's gradations of torticollis that I don't know, but according to Regina, the people that are at the grade he was at are typically considered for surgical consultation because of lack of progress. And so she proposed a kind of a case study to him on this patient. And when she looked at him, he actually had fibrosis of the SCM. And so she started doing research about what happens to tissues chronically after a soft tissue injury. And there's dysregulated calcium regulation or homeostasis, which causes calcification in the tissues. And so this patient had these really big fibrous nodules that we saw on ultrasound. So I examined this kid before the study. And then we looked at a couple of similar patients. And so she put together these other frequencies that have been identified in responsiveness to calcium deposition, and proposed that she was going to soften the tissue and include that in her treatment plan. So we talked about the kind of channel A and channel B condition tissue. So she treated calcium deposition and fibrosis, and then the only tissue she treated was the muscle belly, which is the frequency for that is 46. So we have frequencies for, so this is the frequency for sort of this sarcolemma, but we have frequencies for the myofascial part, and kind of tendinous insertion and different other parts of the muscle. And so this is this cute little guy. So this is what he looked at in 2 months. And he had some residual tilt there. You know, obviously he didn't look as bad as he did at 2 months. What you can see when you look at his final is his second, the B and C pictures, there is a difference in the appearance of his ears. Because of the tilt, he had rotation. So, you know, there's craniofacial deformation due to muscle movement. He has an offset hairline. You see this little bit of rotation. In the second picture, you see kind of more prominent trap on the left side, and you can't really see the fibrosis in these pictures. And I sort of wish that they had photographed that, but it was impressive. And so she treated him with kind of traditional techniques and added FSM, so stretching, massage, strengthening, kind of putting him in gravity eliminated positions where he had to work to bring his head up. And he had really dramatic improvements. And I'm going to go back a slide, but there's this goniometer that they put around the head. And so that's how they measure the head tilt. And so he had major improvements. You know, he's not perfect. You can still see a little bit of difference there, but if you walked by him on the playground, no one's going to say, hey, what happened to your head, right? And so, you know, kind of her follow-up to this, you know, she wanted to see what she had really, you know, really good resolution. So the fibrous nodules completely went away. The tissue felt really soft and gushy. It still had a textural difference compared to the uninjured side, but it sort of validated for us the effects in injured tissues and what we were seeing in our other patients. And so we did a follow-up study for 2 other patients with a similar presentation. And when I left, what we were trying to do was image them with ultrasound to see the changes in the SCM muscle. What we could see was, you know, did it look like the other side? No. But there was less calcium calcification. On ultrasound, you'll see difference in the way the tissues behave and appear when you tilt the ultrasound head. And kind of what the ultrasonographer or the radiologist proposed was looking at it with elastography. So her next study that she's working on is elastography, which is a ultrasound techniques that look at tissue density, and it's used currently a lot for like changes in fatty liver disease, for instance. And that's how they measure fatty liver burden, is through elastography using ultrasound. And so that's what their plan is to kind of further validate this using ultrasound elastography. Now, I don't see this level of torticollis in as many patients here. You know, I see what I'm referred, right? And so it'd be nice to repeat this here in our center, but so, you know, if I see the patients, I'd love to repeat this. We have access to it here. But anyway, very interesting. So this one's, you know, obviously an N of 1, right? But very well done study, very well researched, and very intriguing about how she approached it. And he has had kind of long-standing benefit, meaning he has not had a relapse in his neck positioning. So anyway, so these are kind of 2 examples. So it kind of our current practice with this modality, kind of wrapping things up. In inpatient setting, we use this for pain related to spinal cord injuries. We help it with nerve reinnervation. We use it in agitation and brain injuries. We use it a lot for wound healing, any type of musculoskeletal pain. And in outpatient, kind of a lot of similarities, but a lot more kind of chronic processes. But I think there's a lot of opportunities for research in this. And I just, you know, we're kind of our efforts right now are we're looking at spasticity and dystonia with it. And so we're working on a case series of a number of patients that we've had some sustained benefit. But it's really, again, not everybody's brain is the same, and we haven't had sustained benefit in many, many patients, but there's a number that we've been able to identify who have had really nice effects from this modality. So that's one of the things that's being looked at here is kind of, we want to put together a case series to then advance and get a bigger study if we are able to see some benefit. But I think if you're interested in rehab, it's a neat technique and it's a neat tool in your toolbox. And if you, it's something that's taught around the country, and it's also available online, and then people can get kind of certified with practitioners for the kind of manual technique part. But it's kind of been a major change for my practice over the past 8 years since I learned it, or maybe it's been longer than that. I can't remember. Anyway, so thanks for getting that out, and hopefully that wasn't too long or verbose, but does that all make sense, guys? Any questions about these two kind of studies?
I had a question just about like the technique in general. I know it's hard to tease out, but is there any pattern you've noticed in the patients that do have long-term benefit versus don't?
In terms of dystonia, or in terms of kind of general?
Dystonia, like what you've been working on.
So the patients that we have longer term benefit, it's because we have identified frequencies that match, because we don't have every part of the central nervous system identified with frequencies. It'd be wonderful, but even if we did, you're sort of like looking at an image and trying to figure out what's affected. For patients with true dystonia who have basal ganglia infarcts or damage, those patients have had long-term benefit from it. And so we've seen kind of gradual improvements. And so for some patients, are we fixing them? No. But their ability to have greater comfort and ease of positioning, and if they benefit from it, then we get them a home unit that then they can kind of repeat stuff at home that gives them options for, because it's such a variable hyperkinetic syndrome, meaning it varies by the hour of the day and also positionally, but it affects a lot of musculoskeletal pain. And so we can treat the pain and we can treat the muscle tone. And the patients that we have success with have had kind of greater ability to participate in their environment and be positioned in their wheelchair. So, but I think the ones that have true basal ganglia involvement, but dystonia pathways are very complicated. So everybody knows about basal ganglia, but there's multiple other pathways that are involved in dystonia propagation. So there's thalamic representation, there's caudate representation, there's cortex involvement, there's even frontal lobe involvement. And so it's this kind of complex pathway. So we're interrupting it at one part, right? And so validating that'll be tough, but kind of one of the things that I want to look at is actually with quantitative EEG, to see if we can show where we're treating and validate it a little bit. And so we have a person that does QEEG here, and we're going to try to look at a couple cerebral palsy patients and look at their sort of before and after treatment. We can't really do it during because it'll just like interfere with the equipment. But it's something that I think has been kind of percolating a little bit, and I think would be a good way to validate that we are in fact treating the frontal cortex and not just having some benefit elsewhere that's affecting the muscle tone or whatever we're targeting. So a lot to do, and I don't have a research background, so I need some assistance in planning things and putting stuff together. So that's kind of one of the things that slowed us down, is my lack of PhD behind my name and lack of tons and tons of research credentials, but a lot of opportunities. So if anybody is interested in looking at patients or learning about it or anything, feel free to drop me an email, because we certainly are looking for people to be involved in whatever stage of kind of development of research. So questions about anything else?
I just had a quick question. I know when I did a rotation with you, there was a patient we used this on, I think it was daily, but is there like a certain amount of recommended usage of this, like amount of times
Sure.
per day, things like that?
So depending on what we're treating. So when we first started treating spasticity, you know, we were getting a couple hours, and then we kind of retargeted it, and we're getting kind of like 3 to 5 days of benefit. Dystonia is more short-lived because of the pathways involved. But like I said, there's been a few patients who've kind of had some more permanent benefit, and I'm still trying to wrap my head around that. So dosing is really dependent on the condition, like neuropathic pain, probably once a week. Hypermobility syndromes, if you know, in the absence of other sort of tissue related issues, like once or twice a week. So it does have some long-standing benefit, but like I said, we're not getting rid of Crohn's, we're not getting rid of EDS, we're not getting rid of some of these disease processes. And if you have a hypermobility syndrome, we're not getting rid of that, but it seems to stabilize the joints and decrease pain. And so, you know, for our patients that are more active, a lot of them will treat after like sporting events or exercise and stuff to get their pain down, so they're able to function better and you know, and feel better. You know, so I view it as kind of our big thing that I really look at with most pain patients is quality of life measures, and less about zeroing out their pain. But if they're able to, you know, if you're able to get back to volleyball, I view that as a positive, right? But you still need therapies, and you still need strengthening exercises and bracing and whatever you need to do it safely. So this is a tool, but it's not a replacement for a team of people. That, you know, it's a tool. So it's really fun, it's addictive, but it's you know, you also have to remember that it's not the only thing that people need.
Awesome. Thank you, Dr. Katholi.
Yeah. Questions, anybody else? All right. Sounds like
Awesome.
everybody has other stuff to do. Please enjoy your evenings, and thanks for joining me. And we'll
Dr. Katholi,
yeah.
Thank you so much for your time. Thank you for sharing with all
Yeah,
of us.
no, thanks for having me, and kind of pleasure to be able to share this stuff with people. And good luck with the rest of you guys' training. What is everybody up?